Good morning, Beth. It looks like the waiting room is cleared. So if you want to go ahead and start, you can do so at your pleasure.
Okay, thank you. Let's go ahead and call the meeting to order. And let's go ahead and take a roll call.
Right, Beth, I think that's me now as your official new secretary. So I apologize in advance, anyone, if I mispronounce your name, and please message me in the chat if I do, so I won't next time. Beth Parton.
Here.
Nina Eisner.
Here.
Susan Stewart.
Here.
Dr. Jerry Roberts.
Here.
Heather Smith. Dr. Garth Bobrowski. Dr. Steve Compton.
Here.
Dr. John Mueller.
Here.
Dr. Amisha Gupta.
Here.
John Dadds. Dr. Catherine Hanna.
Here.
Barry Martin. Ken Gilbert.
Here.
Mackenzie Wallace. Here. Anissa Franklin. Sheila Schuster.
Yes, I'm here. It's Dr. Schuster, please.
Dr. Schuster, my apologies. Brian Proctor. Peggy Rourke.
Here.
Eric Wright. And Commissioner Lee.
Hey, Candy, I want to let you know Dr. Bobrowski is on. I think he was muted when he said here.
Okay, thank you.
Awesome.
And Commissioner Lee's ex officio, so we don't count her towards the quorum.
Thank you, Veronica.
Okay, so do we have a quorum?
Yes, ma'am.
Thank you. Next up is approval of minutes from the last meeting. Would somebody like to make a motion to approve the minutes?
Susan Stewart, I make a motion.
This is Nina. I'll second that.
Any discussion? All in favor, say aye.
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 Any opposed? So moved. So we'll move on to old business. And first up is update on reimbursement for multiple visits on the same day. Where are we with that?
Good morning. This is Veronica Judy Cecil, Senior Deputy Commissioner for Medicaid. And just to refresh everyone's memory, this is the primary care tax recommendation. It is still pending and under review. I don't have an anticipated decision date. I do know that there may be some additional conversations about the model for paying FQHCs and RHCs, federally qualified health centers and rural health centers. So it's just an ongoing conversation, and the review as to changing the current model is still under consideration.
Veronica, what seems to be the problem with that? I mean, it seems to me like a no-brainer. It's two different providers seeing the patient.
So it's more complicated than that. We develop their rate, their daily rate, based on the services they provide. So all of that's taken into consideration for the one rate they get. It's called a PPS rate. The difficulty is that if you unbundle that, it's going to affect providers differently. So for them, their rate would change. And they would, if they don't provide, for example, if we unbundle the dental and behavioral health, they don't provide the service that day, they don't get then that part of the rate. So it really affects providers differently. I don't think there's a consensus on the model, and states do it very differently. So it's a pretty deep dive into the reimbursement model. And again, I think there are conversations about, because there are different models to consider. So I think there's additional conversation about whether it's even the one to pursue. But, this is something the primary care TAC is taking up, and we're happy to continue that conversation there.
I have a question.
Go ahead.
I can well imagine that it's complicated. However, it's also not transparent. How is it in Kentucky that I, as a new member of the MAC, for example, might actually be able to learn? Because I think everybody on the call is relatively smart, and I don't want to take our time right now, but it's complicated is probably not a sufficient answer and probably won't get us to solutions. How is it that I could learn more about what's actually the formula and how it works? Because I don't know how to advise if lots of things are complicated. Where could I uncomplicate my mind?
Sure. So if it's the pleasure of the MAC for us to give a presentation about the reimbursement methodology of FQHCs and RHCs, we're happy to do that in a future meeting. Otherwise, I think that this, again, is an issue that is discussed at the primary care TAC, and certainly you could attend that meeting to stay up to date on the conversation.
Thanks.
Beth?
Yeah.
This is Sheila Schuster. My memory may be flawed, but I've been coming to the MAC meetings for a lot of years before I was on the MAC. And this issue has been under discussion for years, literally. And I'm glad the primary care TAC took it up more formally, but
So Dr. Schuster, there was an issue with other providers being able to, non-FQHC and RHC providers, being able to bill for different services on the same day. That problem no longer exists. That I am not aware of any problem with any other provider being able to submit claims for different services on the same date. This is strictly whether or not we pay one PPS daily rate to FQHCs and RHCs, or we change the model.
Okay. So Kent, that it is complicated. It's kind of a different, because we in behavioral health used to be so concerned because somebody would go see their primary care physician or nurse practitioner and then come to us. And it was a race, quite frankly, to see who could get their claim in first, because only one provider was going to get paid. So I appreciate that explanation. I didn't realize this was a FQHC, RHC. So they get paid a set rate.
They get paid a daily rate called a PPS. That rate is developed based on their cost report. The rate can change if there are regulation, and there are federal rules, by the way, that govern FQHC and RHC reimbursement. And so, again, we take, for the development of that rate, we take all the services that provider may provide, dental, behavioral health, primary care, and we develop one rate per day. And so if somebody comes in, the belief is that that rate is supposed to cover all services delivered that day. And so that's the way that model works.
So
And
I have a follow-up question on the behavioral health side, Veronica, and that is that, more and more of our community mental health centers are becoming CCBHCs. And they will receive that PPS rate. So are they going to be caught up in this as well?
No, this is strictly for the FQHCs RHC. The
Okay.
CCPHC is paid under a different regulation. Now, it follows very much the same reimbursement methodology where, it's an integrated daily rate. But they don't, just because we changed the model with FQHC, RHC doesn't mean we have to for CCBHCs. And that's a lot of acronyms. My apologies.
Yeah, I see where Dr. Gupta was just asking about rural health centers and federally qualified health centers, which are federal designations. I
That is
believe.
correct. There are
Yes,
federal rules that do drive a lot of the requirements, but states do have some flexibility. And it is, but the other thing we've been doing is looking at different states. Of course, when you see one state Medicaid, you only see one state Medicaid because we're all very different in various ways. So again, it's very complex, and I'm going to be very candid with you. We have a lot of priorities on our plate. And we have to allocate our resources, and it just, sometimes we can't devote all of our time to one issue. So that's been a reason why this has been languishing for a bit too.
Okay, since the state has changed regulations regarding rural health clinics and FQHCs to include behavioral health to a greater extent, I think it would be helpful for us to have a presentation on this so that we could have a better understanding. All of us are really busy, not in the TAC meetings. And I think it would be helpful for and how that bundling works and what we can do. I guess it sounds like what we can do right now is you can't see the patient for a behavioral health problem and a primary care problem on the same day. You may have to
So
make
you can, and the rate that they get is calculated anticipating more than one visit, more than one specialty. If, for example, a current FQHC or AHC starts to cover behavioral health services, that's called a change in scope, and it would trigger a new cost report and the development of a new rate. So I do want to make it very clear that the rate they get is based on the services that they say they deliver, the cost to deliver those services, and then that is put into a daily rate.
Okay. Then let me ask the rest of the MAC what your pleasure is. Would you like to have a presentation on this, or are you good with the explanation that we've just received?
I don't feel the need for a presentation.
This is Barry, and I'm on the TAC as well, the primary care TAC as well. I think it would be good to have maybe a 10 or 15 minute presentation, Veronica, on this, because it is a very unique situation, and actually Kentucky Medicaid and rural health and FQHCs are unique, and it is hard to find other states that compare to us. So I think it would be worthwhile to spend a little bit of time to educate the other members on the uniqueness that we have, and what we have done to address and look at other states.
Okay, well, thank you. So let's go ahead and do that for the next meeting then.
And I would,
can we include CCBHCs in that? Just at least 3 minutes out of the 15 or something, I think, because behavioral health is such a piece of all of this. And I think the CCBHCs are going to be in parallel model, if not in exactly the same model.
yeah, I was going to ask Dr. Parton if we could potentially update the the wording of the old business item because it does continue to be confused with the past issue of non-FQHCs and RHCs being able to bill for different services on the same day.
Absolutely. I just made a note here that
Okay, thank you.
RHCs, FQHCs, and CCBHCs. So, this has been helpful for me because I didn't know that other problem was fixed. So that's one of the reasons why it looked like that on the agenda. So already this has been educational. Thank you. The next thing is just a reminder. I try to keep things on the agenda to keep us reminded what we're going to be doing. So in March, we'll have an update on missed and canceled appointments and how is that reporting going and is there a common thread? Next up is what is the status on Anthem MCO?
There's no change in the fact that we have 6 MCOs and Anthem is currently an MCO. That court case is still pending.
Okay, thank you. So I'll put that next meeting. Okay, and I guess Veronica, you're still up.
I do think if Pam Smith is on, she was gonna take a.
Okay,
Let's see if Pam's on.
So we are in the process right now of doing an Appendix K modification that will enact the 10% for fiscal year 23 for the waivers. The residential providers, that 50% increase has been in place since the beginning of PHE, so since 2020. So that change will not occur. We also will not be removing the extra 50% allowance that's in Appendix K right now for those providers that sign the attestation to pass through at least 85% to direct care workers. So providers will have the option of billing the extra 10% or doing that attestation and billing 50% for those services that are outlined in Appendix K. And I realize that is very confusing. So we will be sending out kind of a one-page document that explains it better, as well as if we need to, if we get a lot of questions or there is a desire for it, we will have a kind of a webinar just for people to ask questions. And in addition to that, the adult day and adult day training retainer payments, we are targeting them to go out by next week. We're finalizing the calculations on those. And then we will do mass adjustments. The 10% increase will be retroactive back to the start of the fiscal year, so July 1st. And we will work with Gainwell to do mass adjustments on those for claims that had already been billed and paid so that the providers do not have to do adjustments themselves or void any claims and delay receiving those payments. So we're anticipating by middle of February that we can get that in place. I just have to have the final approval from CMS on the Appendix K modification.
okay, so you'll be sending out something to the MAC members about this so we can have a better understanding.
Yes, we can. I'll send it to, I'll work with Kelly and Aaron and get that to the MAC members, as well as we're going to send it out through our distribution list to all of our the waiver provider groups, so that they have that direct communication as well. And so that they understand where to come with questions or what they need to do.
Okay, thank you.
Hello, this is Rick Chrisman with the DDID TAC. Pam, did you say that the retroactive payments would be coming in the middle of February?
Yeah, the process will be put in place that we hope to have the approval and for providers to be able to bill the rate with the additional 10% in the middle of February. The mass adjustment process will take a little bit longer than that just because it will be so large, but I will provide an update on when that will start and when providers can expect those payments.
And when you say mass adjustment, does that refer to retroactive payments?
That would be any claims that have already been billed and paid at the current rate.
So yes, that will be retroactive payments. When you
The
say
mass,
mass adjustment,
the mass adjustments, yes, will apply to make those the payments, any that have been billed since with dates of service July 1st, 2022 forward, any of those that have been billed, any claims that have not been billed, then the provider would go ahead and bill with that extra 10%. However, need to wait until we tell you that has been approved to do that. So, because if you build that today, it's going to just pay at the regular rate until we get those changes, the approval from CMS and the changes in the system. But it will be, the increase is retroactive back to July 1st of 2022, the start of fiscal year 23.
now, is this because CMS approved it, the Guidehouse study, a rate study?
The rate study is a separate track. This is the initial, that 10% increase. However, the rate study is still ongoing, and there'll be more information about those rates, and that still requires waiver amendments and legislative, the reg changes and legislative approval. So this is separate than the rate study. This is based on what was in House Bill 1.
You have shared some of those rates from the Guidehouse rate study. Are those still applicable?
Those, as we had communicated, were all draft and for discussion only. So they may be, so some of what we discussed in the work groups may be with the final rate. And Rick, honestly, I don't have any of that up in front of me, so I don't remember. But those, as we talked about, were all for discussion at that point. And so those will go out for public comment once we get into that process of updating everything.
All right, thank you.
You're welcome.
Okay.
Beth,
Yeah.
this is Sheila Schuster. I think there are a lot of questions out there about the waivers in general, and I wonder if there aren't a number of MAC members that are not clear about how those home and community-based waivers, what we call the 1915C waivers, operate, who they cover, the fact that we have almost 11,000 people on the waiting list, and what happens when there are changes. We had a big discussion at the BHTAC about the acquired brain injury waiver, and I wonder if, and you know, I've been doing this a long time, and there still are lots of questions I have about the waivers, but I wonder if that's something that other MAC members might want to, again, at a different meeting, have a presentation, kind of an overall presentation about what the waivers do, who they serve, and you know, what kind of money we're putting into the waivers, what we hope to do with them. Just a
I
thought.
would be more than happy to, if that is something that you all would like in a future meeting, would be more than happy to do that, because I understand the waivers are very confusing, especially if you don't deal with them day in and day out. And even when you do deal with them day in and day out, there's still are nuances, and it can be complicated to understand. But I would be more than happy if the MAC members would like that to do that in a future meeting.
Okay, I would like that. I don't have a clear understanding about all the waivers.
It looks like you're getting some other agreement in the chat as well.
Okay.
We'll have to start meeting for 4 and 5 hours to get in on this information. I'm not proposing that, and the earlier discussion is one that should take priority. But I do think that the waivers are just incredibly important, and people don't think necessarily about Medicaid and the waivers. You know, I think it's and we're trying to develop a waiver for folks with severe mental illness. So you know, even that needs some explanation. So thank you, Pam.
You're welcome.
Information on the state's website on waivers, but I didn't know if there would be any kind of a info sheet or something that could be emailed to the MAC ahead of time. That
We can do that. We actually have some of that already, so I can I'll get with Kelly who is our wonderful communication liaison, and I will, we can get some of that out to you all. Just as reading, as some light reading ahead of time. But no, we have some kind of one page, just quick documents that we could send that have background on the waivers that probably would kind of, we call it waiver 101 basically. So it's kind of from the start to understand them. So I'm more than happy to go ahead and get that sent out to you all.
Okay, great. Thank you. Okay, let's go on to next item. That would be still under the commissioner's report.
Yes, so I think you asked, we're seeking a conversation about increased reimbursement for providers. You know, this is something we've been struggling with because we have had almost every single provider type that we deal with make a request for increases. And across the board increases are just not feasible for us. And instead, what we've been trying to do is look strategically at each of the different fee schedules and the services that are provided to see where could we maybe increase some of them to incentivize services that we know will lead to improved outcomes, preventive care. So that is what we did with the recent addition of adult services for dental, vision, and hearing. Is we looked at research and some of the codes that we cover and services we cover for our population, and where can we sort of get the biggest bang for our buck, in other words, because we have limited dollars. We do have a budget that we do have to stay in. And so what we've started to do and what we plan to do is start asking the tax to sort of refocus and look at the services that they provide, the codes that they use, and what are the ones that we could raise to increase access to, and that goes not just from the provider side, but to, to improve the members' care and improve overall health. So those are the conversations that we're having, because candidly, we do not have the budget to just do across the board raises. We get that costs have increased. We understand that. We feel it too here. We've had difficulty recruiting and retaining staff. But again, we have to work within our budget. So that is kind of where we're at right now. Again, we do ask and are asking the tax to help us with this issue by looking at, what can we work on together strategically to increase or incentivize, to increase rates to incentivize outcomes.
So which providers recently received increase in rates?
So what we did with dental, vision, and hearing is that we added services for the adults. So now adults have access to glasses, they have access to hearing aids. And in dental is probably the most significant change. We added a second cleaning. We added, well, Dr. Borowski, I see your hand raised. We did increase the rates for adults to the children's rate. And we took also some additional increases for access to oral surgeons. So that's what we've done so far. And of course, we have the increases in the waivers, which again is a pretty significant amount. But I see hands up, so I don't know if Dr. Parton, you want to hear from the members.
look at the, can see, got their hands up.
Dr. Bobrowski had his up first, I think, and then Nina.
Okay. Okay, I'm having trouble seeing it on my. Okay, go ahead, Dr. Bobrowski.
Well, number one is from dental. Well, we appreciate, the time, effort, and the increases that have been made. One question I had was, were all the adult rates moved up to the children's rate? Is one question I had. And I know there's been more Kentuckians added to the Medicaid rolls. It just seems like every time we have a meeting, there's, been more added, and that's not in my control, or commenting is probably not going to help anything there. But one of the things that, we see even, from our staff, from our other patients, it's like there seems to be plenty of money available for MCOs to give. They just call them freebies, or added benefit, value added benefits, I guess is a technical word, but it just seems like that there's more and more money available to the MCOs to give away perceived, not always, but perceived needs or benefits that those used to not be there. And they're spending millions of dollars per year on those. And, we've got staff in our offices that say, well, boy, I never did get any help for this, but I know I'm preaching to the choir, but I'm just trying to think of ways that, maybe money could be garnered, to help with just the cost of our services, from our healthcare professionals. And I just wanted to put that out there. Just not totally my views, but the things we hear about from dental staff from multiple offices, through the Kentucky Dental Association phone calls. So I just wanted to pass that on to the MAC. Thank you.
So to answer your questions, we did not raise all of the adult services to the children's. We only did those that we added. Again, trying to be strategic in driving the increase in those services that we think will reduce, first of all, hospital ER visits. We pulled, and we have an enormous problem with adults going to the ER for dental care. So, we're trying to redirect that to services that could be provided by a dentist outside of the ER. So there's that. The value added benefits that managed care organizations provide are not part of the funds that we pay them. So we pay a per member per month capitation rate to the MCOs, and they have to spend 90% of that money on healthcare services. If they do not, we will claw that money back. We will require them to pay it back. So they have to spend 90%. And the other 10% is for care coordination and administrative costs and and taxes and other expenses, but at least 90% has to be paid for healthcare services. So the value added benefits, while I understand, there are some really great incentives on that for members. It is to incentivize their, utilization of services, especially preventive care, for maternity care. You have to remember who our population is.
Right.
So we're talking 138%, which is just the expansion population, they make $18,000. So, And, and a lot of the commercial programs offer incentives to incentivize behavior. So, they're really trying to focus, and a lot of those programs are focused on their social needs too. I mean, food is medicine, and GED, covering GED. So it's really trying to look at the person as a whole, to try to help them better their situation. So I think that hopefully those answers your questions.
So when you say the increase was for adults, are you talking about dental, or are you talking about the E&M codes?
So I'm happy to send you the fee schedule, which can, I don't have the codes in my head, but they were various dental codes.
Okay, so not like primary care codes. They were the dental codes you're talking about.
Or dental services, yeah.
They're on the state's website listed for hearing, vision, and dental. They're already all up on the state's website.
Okay, I just wasn't clear which rates she was talking about. So did the physician rates also get increased? Did I read that?
No, we've not done an across the board or any other strategic. We are currently looking at the physician fee schedule, and we are updating it like we normally do annually with CMS, but again, trying to consider, where can we be strategic for maybe increasing a handful of the codes. We are considering that, especially around preventive. And then for behavioral health, we are also looking at that, and we have codes on the behavioral health fee schedule. They're called H codes that aren't tied to Medicare. And so they've gotten no adjustment since they were added. And so we're looking at those to see what we can do to do an annual review of those codes. So these are all, under consideration. And again, I mean, I think what we would like for the tax and the MAC to do is to think more strategically on what are the codes, what are the services that we can increase the reimbursement for those codes and actually drive better outcomes.
Okay, so the increase that you're looking at strategically, is that coming from savings that were supposed to go to providers from Senate Bill 50?
So there was nothing requiring savings from Senate Bill 50 to go to providers.
Okay, I guess I have that confused with something else then.
But
Okay.
From Senate Bill 50, we have seen, due to, primarily increased rebates that we get on drugs. We are getting higher rebates that, can help offset the costs of the program. But keep in mind, those, provider reimbursement increases have to be sustainable. So if we have one-time funding, that is not sustainable. We have to make sure that, first of all, if we give something, it's hard to take it away. So, so we would need budget authorization in our future budget to sustain those increases.
Okay. Could I ask that in future meetings that we can just get an update on where we are looking at these different codes?
Sure, absolutely.
Okay, so I'll just keep that on the agenda. We can get updates at each meeting.
And Beth, Nina, and Dr. Gupta both have their hands raised as well.
Okay, thank you. I'm so sorry. I can't see that. I don't know how to, I guess I'm not technologically savvy enough to see that, but anybody who has your hand up, go ahead and speak up, please.
Veronica, it's Nine Eisner. Just a quick question. I know the BHSO rate increases are supposed to be out sometime in January. I thought and retroactive back to January 1. Are they out yet or have I missed them?
No, in fact, thank you for that question. We, CMS released updated rates as early as a couple of weeks ago. So we were on track, and then they threw that loophole. So we're really close to making those changes, and hope to have the fee schedule up sometime in the next week. I do want to say, and I think one thing the commissioner has really tried to emphasize, and she said this to the dental TAC, and I think maybe to a couple of other TACs, is that, you know, we're proposing some changes like we did with dental vision and hearing. And what we appreciate is that it has started a conversation and allowed us to get feedback and continue to have that discussion for a future change. So I guess I just want to make sure everyone understands that, you know, if we publish the fee schedule and it's not to your satisfaction, you know, we really want to continue the conversation and look forward to having, again, those strategic conversations about what can we do working together to improve the health.
Thank you, Veronica.
This is Dr. Gupta. Veronica, thank you for everything that I know you all are doing for all of us. I just want to reiterate a little bit. This is a major topic in our physician talk, access to healthcare.
Dr. Gupta, I'm so sorry. I can barely hear you. I don't know if it's me. I apologize.
Let's see. Can you hear me?
Yes, it just sounds a little muffled for some reason.
Okay, I'll try to speak a little bit louder. This is a major topic in our physician talk, increasing access to healthcare. And, you know, this is a very long investment, but increasing reimbursement to primary care physicians especially will really save money in the end. You know, we're on the brink of a physician crisis, trying to keep residents in Kentucky going into primary care. We're seeing fewer and fewer residents wanting to go into primary care and especially staying in the state. So, you know, as you all think about the fee schedule, please try to keep, and I know you all already are, keep their physician reimbursement, especially for primary care, in mind, because otherwise, you know, it's going to end up costing more money with people getting less access to healthcare or a lot of duplication. I just wanted to do something.
Yeah, thank you for those comments. Workforce is an issue, and sadly, I think it always has been, but you're right, it kind of is reaching a crisis point in several of the different provider types. And we recognize that, and I know there are efforts beyond Medicaid, more of a statewide effort to try to deal with those. And we are willing to be at the table and try to be part of the solution there. And we are looking at, again, you know, a handful of primary care codes that, you know, it might make sense to go ahead and raise those. And then the other thing is, you know, we really want to monitor. We just don't want to throw money at the problem. We want to make sure that we're spending our money wisely. I mean, we're stewards of the taxpayer money. We have a lot of people to serve and cover, and unlimited funds. So I think that's why we tried to step back and take a more strategic approach. And I'm sorry, I keep using that word, but you know, to try to find ways to use the funds we have more efficiently and more effectively. And that's why, again, we want the conversations. We want the tax focused on this and helping us solve the problem.
Veronica,
I have another question. Oh, I'm sorry, Dr. Seuss.
I was just gonna ask, with the governor's executive order, physicians now are being asked to do certification of these diagnoses so that people can go to other states and get medical cannabis. And is that a service that's being reimbursed for Medicaid patients?
No, Kentucky Medicaid cannot cover that.
Cannot cover the physician's time in doing that certification.
So if the physician, I don't think I'm prepared to answer that question, Dr. Schuster.
Okay. Well, it's been a conundrum because some of those diagnoses are behavioral health and we're trying to figure out, if I as a psychologist make that, I'm not in the executive order. I'm just trying to figure out how all of this is going to work.
Well, I will tell you that we cover medically necessary services, and that includes a physician or a practitioner, office visit. And so that's a covered service. That's probably about the extent to which I can address the question.
Sheila,
Okay.
Sheila, I think that those certifications will probably be based on history. So if a patient has those 21 conditions, that would be in their history. And so the provider could just write a note stating that the person has that condition.
What we can't pay for is the canvas.
But you can't pay for, yes, right now, yeah, I understand that.
But, again, a physician seeing a patient, making a diagnosis, I mean, that to me is an office visit.
Okay. So the physician looking at the record because they've got a request and coming up with something and signing it is just.
If it meets the requirements of the code.
Yeah, right.
And
All right, thank you. It's, obviously as this thing rolls out, there's gonna be a lot more questions. Thank you, I appreciate it.
You're welcome.
Dr. Bobrowski, did you have another question or is your hand still just raised? I think you're muted.
Oh, I'm sorry. I was just kept waving at you. I don't get to see you in person. I just kept waving. I'm sorry. I'll get it down. There, sorry.
Okay.
If you have your hand raised, you have a question?
Who,
Yes.
me?
I do. This is Patricia Bautista Cervera, Dr. Patricia, with the Disparity and Equity TAC, and also member of the Board of Health in Louisville Metro. And regarding the reimbursement update for providers, I'm part of the immunization committee. I was, and there's been several talks about the reviewing for the fee reimbursement for vaccinations. Have you reviewed that, and could you share something about it?
I don't have any information to share at this time. I'm sorry. Happy to take that back though.
Okay, do you have anything else in your report, Veronica?
Just a couple of things. So one is we're going to start provider forums, our Reconnect, Reunite tour. And those will be in April and May, and we will share more information about that as we confirm things, and we'll make sure the MAC and the TACs are aware, and we'll be doing a campaign, an outreach campaign to providers to make them aware we'll be in your area. We did file our community health workers state plan amendment with CMS. It's currently pending. We did request an effective date of July 1 for 2023 so that we can be prepared, because it's requiring system and policy and several changes to implement that. But we'll keep you posted on the approval of that state plan amendment. As you all may have heard, annual renewals are going to start. So the public health emergency has not ended, but at the end of December, Congress passed and the president signed a Consolidated Appropriations Act that delinks the requirement for us to continue to cover folks. So we will be starting with those who have a renewal date of May 31st, 2023. We will restart annual renewals. We have been working for this day to come, and we will have 12 months to renew every person in Medicaid, so over 1.7 million folks. We'll be allocating those cases over the 12 months to try to help with our workforce issues and to make sure that we are able to provide the support and outreach to folks who will be going through that renewal. I think fortunately for Kentucky Medicaid, we have a really great system that is capable of going out and pinging the federal hub and other databases to be able to automatically renew somebody because we can verify their information that way. So they will be what's called passively renewed or automatically renewed if we're able to verify. If we're not, then we'll have to request information from them. And then there are other Medicaid members who have to go through an active renewal. And so they'll receive a renewal packet and we'll have to provide information to us for us to be able to make that determination. We are planning lots of campaigns around the renewals. We'll be tracking at the individual level, somebody who's going through a renewal to make sure that they are responding to our requests. Our managed care organizations are going to outreach to their members directly to make sure they know that they're up for a renewal and they're taking the appropriate action. The other thing to keep in mind is that we do know that people probably are no longer eligible. And the primary reason for that is income. They make over the income limit. So we will make sure that they understand they can choose a qualified health plan on the exchange, or they can move to employer-sponsored insurance if they have insurance available through their employer. We'll be helping those folks understand what their options are. And then for anyone who aged 65 or older during the pandemic and did not enroll in Medicare, they will have to enroll, and they'll have a special enrollment period of 6 months when they're discontinued from Medicaid, and they'll be able to do that without a penalty. So those are the folks we're really going to focus on. We do not want gaps in coverage. We do not want to disenroll somebody who is eligible because they didn't return information. So we'll be working really hard to keep those folks covered.
So this is part of the unwinding?
It is. It's just that what's confusing is the public health emergency, it has not ended, but renewals will have to start.
Okay.
Then the last thing is that honestly, Dr. Parton, if you want us to talk a little bit more about our plan at the next meeting, because we'll be restarting renewals at that point, we can maybe provide more information. But the only other thing is we're monitoring legislation. The General Assembly session started early January. They come back February 6th, I think. And so, we'll continue to determine if there's any impacts to the Medicaid program.
Yes, that would be helpful, I think, at the next meeting to let us know how that's going.
Okay. That's all I have.
Okay, thank you. Okay, so next up is maternal child health update.
Dr. Turner, you should be a co-host now if you need to share your screen.
I shall attempt. We'll see what happens. Okay, what are you guys seeing? Oh, I can. Are you guys seeing my screen?
We can, but it's real little.
Oh, let's see. It's probably showing the wrong screen. Let's see. How do we do that?
Correct slide, maternal health update, January 26th, but it's real little.
All righty.
Dr. Terry, I think if you go to the top to view options, you should be able to change the format. How you had it a moment ago, we could see it
I
clearly.
I don't see what it says view options. Let's see. Show taskbar. No. Oh, gosh.
Maybe that's on my screen from where I'm the host. I apologize.
I know it usually has a view option thing. And now what do you see? Still
Looks
small?
It's a little bigger.
A little bigger.
Dr. Terry, do you want to send it to me and I can share?
Yes. I shall, maybe. That would go. So who, to you, Veronica, or to you, Erin?
Yeah, you send it to Veronica.
Okay. Let me stop sharing. And then I should, I'm so sorry. I was actually very worried about this.
Beth, do you want to go to 6A while we're waiting on Veronica to get that pulled up?
And I think it's because I have two screens. And so I always mess up when there's more than one.
Okay, so that issue is DMS brief overview, what was covered before the overturn of Roe v. Wade and what's covered now.
There is really no difference. Go ahead, Veronica.
Well, so we want to remind everyone that we're required to follow state law. And so prior to the overturning of Roe versus Wade and other federal and state laws that went into effect, we covered abortion in 3 situations because the state law allowed us to. And so that is the health of the mom, rape and incest. Since the state law has changed, we are not allowed to cover abortions with the Kentucky Medicaid funds. I need to be able to share, Erin. Okay.
A question. A question that she's frozen.
Okay, there you go.
Yay, it works. Okay, thank you very much. Well, I guess I can't forward them, but we're just going to have an update from last May, I believe, was our last talk about maternal health. So next slide. And last time we talked about a little bit about serious maternal morbidity, and that's when moms have a near miss. So they did not have a mortality, but it was close. And so we found that 20.5 moms with a serious morbidity were 20.5 times more likely to die within that year postpartum, the postpartum period, than moms that did not have a severe morbidity. We also learned that 79% of our maternal deaths are preventable, which is a sad number, but that means we can do something about that. And then suicidal ideations was the most common reason for moms to be admitted to the hospital during that year postpartum. And that was for 2018 and 2019, which it's very uncommon for moms to be admitted to the hospital within that year. But the fact that suicidal ideations was the the primary reason is a little scary. And so we kind of talked about all that stuff last year or last time. So next slide, please. So when you think about maternal health, again, we have the pink, which is really the prenatal period. And we have labor and delivery, which is green, and then the postpartum period, which is purple. So today we're going to talk a little bit more, because we haven't yet, about the green circle, about things that are happening within labor and delivery, low risk C-sections, things like that. And then we'll switch gears, talk about postpartum in that purple circle, and that will include some information about moms and babies, because you can't really talk about the babies, the mamas, without the babies. Thank you. So next slide. And then overarching everything, we have pretty large racial disparities within Kentucky maternal health population. So we will touch on health disparities as well. So next slide. When we're talking about racial disparities, Kentucky's population is primarily white, so 87.5% white and 8.5% Black, and that's statewide. We also know that the majority of our women live in the metropolitan areas, and Black and white women have access to the same hospitals and the same specialists, the same referrals. Both are just being cared for by the same system within those metro areas, yet our racial disparity is huge. Next slide. So our maternal mortality annual report tells us that 42.1% of our maternal deaths are for African Americans, and 17.2% is for white. So that's huge. So even though we only have 8.5% of our population as Black moms are dying at a much higher rate, even though they're within the same system of care as the white mom. So that's something to think about, and something that we, as a system, can probably address and do something about, because just with the people in this room. Next slide. When we talk about serious maternal morbidity, Black women are also at increased risk. They're 1.7 times more likely to have a serious morbidity, one of those near misses, than the white women. And if we can decrease those serious morbidities, we can decrease maternal mortality. And those are hard. So the serious morbidities, if you remember, those were hemorrhage, needing a transfusion, cardiac events. Those were those serious morbidities. And women who undergo a cesarean delivery are at an increased risk for developing one of those morbidities. Next slide. So when we look at our cesarean deliveries in 2020, nationwide, 31.8% of births were born by cesarean. And in Kentucky, it was 34.3% of births, which I think is nuts. I mean, that's more than 1 in 3 babies are born in Kentucky are born by a C-section. And I know you're saying, well, nobody does a C-section for no reason. You know, everybody has a reason, and that's true. So one thing we can look at is the low risk cesarean deliveries, and those are the deliveries where you have a new mom, so they the first time being pregnant, their term. It's only one baby. You don't have twins or triplets, and the baby is positioned head down. They're not breech. So that's considered a low risk delivery. And even in that case, 27.4% of Kentucky births for low are born by C-section in that low risk population. So more than 1 in 4. And of course, you know, if you have your first baby by C-section, you're probably going to have subsequent deliveries by C-section. So our rate is 27.4. The national rate is still incredibly high. It's 26.3. But if we can lower the low risk C-sections, we will lower the subsequent C-sections, and our moms will be safer when they have babies, because they'll have less morbidity. Next slide. So let's shift a little bit. So that's part of the green Venn diagram circle for L&D. Well, let's talk about postpartum care and the mother and baby outcomes. Next slide. So when we know we have a big problem with substance use in our state, we looked at 5 years of Medicaid data, and we found that 22,451 births, babies were born to moms with SUD in those 5 years. Of those babies, about 6,000 were diagnosed and treated for neonatal abstinence. So we kind of concentrate on this neonatal abstinence number, but we forget the bigger picture that only about a quarter of the babies born to moms with substance use actually develop neonatal abstinence. But the babies are still exposed to drugs in utero. So this is a big deal. Also, women who have substance use disorder are more likely to have a premature baby. And so it will affect the baby from the beginning. So let's see what our numbers are for the babies. Next slide. So the March of Dimes report card comes out in November, and this is from the 2022 March of Dimes report card. And we actually went up in our preterm birth rate, which is terrifying. The preterm birth rate is based on 2021 numbers, so that's 12.0%. The national number was 10.5, so 10.5, 12.0, that's not good. Infant mortality rate, as expected, kind of follows that preterm birth rate, and in 2020, our infant mortality rate went up to 6.2%. So this is terrifying to me that these rates are going up. Now, when you look at it, I mean, you can, all right, at least I think I can justify in my head at least some of the increase being due to COVID, you know, because of the timing of this data. But I don't think you can account for all of the COVID. You can't put it all on the COVID's shoulders. So something else is going on. Next slide. And then again, we see that there's a big racial disparity there. So in Kentucky, the preterm birth rate among Black women is 31% higher than the rate among all other women. So that's huge. Next slide. We know that we have about a 60% attendance rate at our postpartum visits in Kentucky. You know, some areas are doing a little bit better than the other, and we have a program going on to try and increase that postpartum attendance rate. And I'm justifying it because I know the goal is 75%, and it just seems kind of like a wimpy goal, because really it should be 100%. But next slide. When we looked at the postpartum visit rate by race and NCO, we saw that our Black women are having a harder time getting to their postpartum visits almost across the board. And whether that's lack of transportation, you know, other barriers coming into play, but our moms are having more preterm babies. Our Black moms, more preterm babies. They're having more serious morbidities, and they're having harder time getting to these postpartum visits. So we really need to try and focus on that and try and get, you know, make it easier for moms to get to these visits. Next slide. And why is the visit important? You know, it assesses the mother's physical recovery from the childbirth, obviously. It is a time to monitor moms for serious morbidity. If they had a morbidity in labor and delivery, you know, how have they recovered from that? It also gives you time to assess for chronic conditions such as hypertension, diabetes, also looking into screenings for SUD and postpartum depression. And then the ongoing care of the woman, including family planning, contraception, birth spacing. It's an opportunity to counsel on breastfeeding, on nutrition, other preventive health issues, exercise, and linking moms to other services in the healthcare field or community-based services if needed. So next slide. I wanted to point out, it's an opportunity to screen for postpartum depression. And if you think back, we already said only about 60% of our moms get to these visits. So yes, we need to include that, but we need to make sure that our moms are getting screened at the visits. Next slide. So about 1/3 of our Medicaid moms have an ER visit within that year postpartum. I thought that was a high number, and I guess it's not when you consider all these other high numbers that we've talked about today. But these are young women in the prime of their lives, you know, with other responsibilities at home, yet 1/3 of them go to the ER for a personal problem during that year postpartum. And 1 out of 10 of those ER visits are due to a behavioral health concern, is, you know, depression, anxiety, substance use. So that's a big group of people. And so if moms are going to those postpartum visits and they're getting screened for substance use, depression, anxiety, then they might not be going to those visits, and we can link them to services sooner so they don't end up being admitted for suicidal ideations. So next slide. So really, a very simple thing to do is screening moms during that postpartum visit for behavioral health concerns. That will allow for earlier referral, earlier treatment, and really can lead to much better outcomes for our moms and our babies. And that's it. Thank you.
Dr. Terrio, Eva Stone had a question in the chat. Did you see that?
I did not.
Dr. Stone, did you want to ask a question? Or Eva, I'm sorry, I'm not sure if you're here. I apologize.
I was just curious, Dr. Thoreau, if women, as far as the HANDS program in Kentucky, if Black women are less likely to be participating in that program than white women, or has the data been looked at in comparison with their participation in the HANDS program? Because part of that work is supposed to be to make sure women have healthy birth outcomes.
I do not know the answer to that. We can get with Dr. Bada and her group in public health and find out. That's a great question. Thank you.
Thanks.
Dr. Schuster?
Yeah, Dr. Terrio, this is great, and I look forward to getting the slides. I wonder, back on the cesarean deliveries, did you look at that by race of the moms? I'm just curious. And also whether the cesarean rates are different for Medicaid moms than for non-Medicaid moms.
I did not look at that, but that is on my list. That is the next thing that we're looking at.
Yeah, I just think that just anecdotally and something that we've been concerned about for a long time is that Medicaid is a reliable payer. That the rates may not be great, but I just wonder if there is a higher cesarean delivery rate for Medicaid moms over commercially covered moms. And then I wonder also about the racial disparities.
Right, and
Yeah.
we'll look at that. I do know for our fee schedule, the providers are reimbursed the same for a cesarean delivery and a vaginal delivery.
Oh, okay.
So there is no incentive, monetary incentive to do one over the other.
And the hospital reimbursement is the same?
Yes.
Ah, okay. I did not know that. Thank you.
Dr. Gupta has her hand raised.
Dr. Gupta?
Hi, this is a twofold question. The last service before Ms. Cecil spoke about the routine weight of the new changes.
Gupta, we can't hear you.
No?
Oh, that was better.
Okay. I left service right before Ms. Cecil spoke about the new changes with Roe v. Wade. Did she say that now Medicaid will not cover for rape, incest, or risk of harm to the mother? Is that correct?
That's correct, Dr. Gupta. The state law does not allow us to do that.
Okay. So my second question is, Dr. Terrio, do you think that our report card is going to worsen with these changes?
It may. Yes, our March of Dimes report card may get worse. because of that change.
Dr. Terrio, as always, this is a wonderful presentation, and I think we're all glued to watch because it's such an excellent presentation that you always give. I had a question. We had asked about hepatitis C prenatal screening and the number of cases and number of people treated. Do you have that information?
We have looked for that, and because a lot of the hepatitis C screens are within bundles, it's not, we can't just check one code and find the rate, but they're within like a prenatal bundle, things like that. But I do know that we've checked with universities, with the teaching programs. The Kentucky Perinatal Quality Collaborative has also checked, and all of the OBs say it's standard of care.
Okay.
That they do it with every delivery. I also know from the pediatric side, when we're in the nursery, we make sure that lab is done before we let the baby go. So there's a double check there.
Okay, so the missing piece then is the number of cases and the number of people treated, because it's bundled in, so we can't see that.
That's true.
Okay. Okay, well, thank you very much. And
Yes, I have one other question, if I may. Dr. Terrio, I can't believe I just lost it. Oh, I know. So the screening for postpartum depression, I think it's now called perinatal mood and anxiety disorders, PMAD, they call it, can be done at that postpartum visit by the OB and get reimbursed. What are the guidelines for pediatricians in terms of, should they be doing that screening all through the postpartum period? And somebody told me it was for the whole 12 months afterwards. And then I heard it was only up to 6 months postpartum. Do you know that? Do you know the answer to that?
It is recommended that pediatricians conduct a postpartum depression screen on moms throughout that first year of life. I do not think that happens a lot of times, but people will go up to, people who are the pediatricians that are screening for it will go up to about 6 months on those screens. Kentucky Medicaid reimburses for, because you can argue, well, that's not my patient, the baby is my patient. How can I do a depression screen on a baby? But Kentucky Medicaid allows you to do that screen on the mom and then bill it as part of the baby's chart.
Okay, so you think the common practice is maybe up through 6 months?
Yes.
But, we would really like to see it, because I understand from my psychology people that treat this in women that sometimes it doesn't show up until toward the end of that first year postpartum.
Yes, that is true.
Thank you.
And you're right, you really want to keep that in mind. It's kind of easy to keep that in mind when you have a little infant, but when you have a little crawling thing there, you kind of forget about the whole birth stuff, chasing them.
Yeah,
but
thank you.
you're right.
This has been eye-opening and discouraging in some ways, but so glad that you're looking at this data and that we're looking at particularly the health equity issues around this. Thank you.
Thank you.
Just one follow-up question. Is that covered in primary care?
Yes.
Okay, because others are not showing up for their OB screen postpartum exams, but they are showing up in primary care.
Yes. And I think that's the reason, that's the reason that it's paid for, because you're right, moms may not show up for their OB visits postpartum because they're busy, but they're bringing the baby to a provider. So
right, or coming in for a sore throat.
Yes.
Okay, great. Well, thank you. And I will put this on the agenda for an update in 6 months.
All righty.
Dr. Borowski has his hand raised.
Okay.
Just a quick question. And kind of being new on the MAC, a lot of new information for us guys here too, but just as part of the postpartum visits, training, whatever you word that as, do the moms get any like oral health training, like to help prevent baby bottle syndrome with what they put in those little babies' mouths? Because they, at about, 5, 6, 7 months is when they start getting teeth in. And, sometimes by 14 to 18 months, their teeth are rotted out already. So I just wondered if there's any training on baby bottle syndrome.
That there is, as part of the pediatric curriculum, and warning, I mean, there's, what to put in a bottle, what not to put in a bottle, things like that. So yes, there is training on that. I have them somewhere, my teeth, my milk bottle carries teeth, that I had a, little teeth thing, and I can whip it out of my pocket and I can, show it to moms. And yes, pediatricians teach, as soon as you have teeth, you start brushing those teeth. When you go to bed at night, you treat them like your teeth. So if you brush your teeth and you go to bed, then the baby should not have anything but water after that time, or you're going to have to brush it again. It's nothing magic. They're just like your teeth. You have to take care of them. They only have to last 100 years. So hopefully you take care of them.
Great job. Thank you.
Okay, thank you. So let's move along. Because we're gonna run short on time, I'm afraid. Next up is update on workforce shortage from Dr. Sheila Schuster.
Thank you. And this will be quick, and I appreciate Erin sharing my screen because I'm so bad at it. Next slide, please, Erin. This issue of workforce shortage is one that I've been working on in a licensure vein since the late 70s, early 80s. We know we have workforce shortages. We think we're pretty good at estimating what the need is. We've seen those estimates, for instance, on nurses coming from the Kentucky Hospital Association and from the Kentucky Nurses Association. But I'm going to tell you, we have lousy data on what our current workforce capacity actually is. So the state commissioned Deloitte back in 2013. So it's been 10 years since we've had a statewide or a state authorized study on this. And they pointed out that their data sources, which were the licensure boards, created flawed data, and some provider groups were omitted. Next, please, Erin. So I gave you the link. That Deloitte Kentucky Workforce Capacity Report is still available on the CHFS website. And as I said, it was commissioned by the state, published in May of 2013, around the time of the implementation of the Affordable Care Act and the Medicaid managed care. So the licensure boards and the healthcare professions that they looked at were physicians, including PAs, nurses, including APRNs, RNs, and LPNs, dentists, optometrists, and then they kind of lumped together this group of mental health providers. So some of you who are on the MAC and some in the audience will say, well, we weren't in there and we're healthcare, and that's absolutely true. So the therapy providers, OT, PT, and speech, the chiropractors, the podiatrists, I mean, there's a number of other healthcare providers that they didn't survey at all. So it was a narrow focus in some ways. Next, please. So just on the mental health side, since I'm a psychologist, I look particularly at this, and this is how they define the mental health providers. Psychiatrists, licensed psychologists, which in Kentucky are those at the doctoral level, did not include those that are licensed at the master's level. Licensed clinical social workers, licensed professional counselors, marriage and family therapists, and then alcohol and drug counselors. They did not include any of the psych mental health APRNs, which was certainly an oversight, nor did they include any of the mental health professionals working under supervision. And there is a requirement in every mental health profession, probably different for medicine and for APRNs, but in all the others, to work under supervision for X number of years, some with a master's degree and some while in training, and they provide services. and are billable, some of them by Medicaid and other insurers. So when they defined the need for mental health, and they used some national statistics to try to figure out how many psychologists do you need per 100,000 people, how many marriage and family therapists and so forth. They didn't do it for the individual professions. They lumped all the mental health professionals together as if we all provide the same mental health services, which we do not. So some prescribe and others do not. Some are able to diagnose and others do not. Some treat certain conditions only. For instance, the alcohol and drug counselors or the marriage and family therapists are only treating some mental health or behavioral health situations and not all. Next, please. So the Deloitte report actually consistently noted the shortcomings of the licensure board data, which include, just for starters, the location of practice sites, whether the individual was practicing full or part-time or whether they were practicing at all. And I will use myself as an example. I've been licensed since the late 70s, just to show you how old I am. I stopped clinical practice in 2000 when I went full-time into my advocacy work in Frankfurt, but I kept my license. So I've kept up with my CEs and all the requirements to keep your license. And I did that because I testify fairly frequently in the legislature, and I want to be able to identify myself as a licensed psychologist so that they kind of know where I'm coming from. So I'm counted in that, you know, if you go to the Board of Examiners of Psychology and count how many licensed psychologists, Sheila Schuster would be in there, but I'm not providing services. So in terms of our workforce, because we're looking at service providers, you know, you get a false impression. Also, most of the boards don't ask the graduation date that you got your professional degree. And you think, well, why do you need that? Well, there are estimates that you can make in terms of about when people will retire, because we're losing people. People may be retiring earlier than 65 or whatever that date is, but we at least ought to be able to estimate that. Other problems that Deloitte noted were that some of the boards had duplicative or missing data. They also failed to note that some individuals held multiple licenses, which is not uncommon among, for instance, the mental health providers. So someone may start out in the field of social work and then decide to specialize, if you will, in alcohol and drug counseling, get additional training, and then they keep both licenses. Well, we're obviously not doubling the number of providers, but we're just halving the person, if you will. The most common data point that was missing was the county of the individual's practice. Most of the boards only have your single address. And for most of us, it may be our home address, since we may have various practice sites. The Kentucky Board of Nursing was noted to have the most accurate data, and it consistently included the county of practice. And I will say that they recently updated their renewal form, so they are asking a lot of the questions that we're going to cover in the next slide. So next slide, please. So while KBN, Kentucky Board of Nursing, comes the closest, no licensure board currently requires all of these data responses, the addresses of all practice locations and the percentage of practice in each. So we know there are people that have offices in several counties, for instance, and when we're trying to look at access to services, we really need to know if services are being provided by that provider in multiple counties. The percentage of your full-time practice, which is that you're actually doing. And again, my example, I would put down 0, because I don't think you can count what I do with legislators as delivering mental health services. What are the specialty areas of practice? Many of the physicians, the nurse practitioners, many of us in psychology and in other fields specialize, and it would be really helpful to know that. What's the race and ethnicity of the licensee? This may be more important in terms of behavioral health, because I think it's really important for somebody coming into therapy to sit in the therapy office and look across the room and see someone that looks somewhat like them, may have some of the same lived experience. I also wonder if it isn't true across healthcare providers, and would be really helpful to have that information. What's the capacity for meeting some specialized patient needs? English as a second language or interpreter services? Is the provider especially trained to address LGBTQ plus kinds of issues? Are they equipped to deal with different disabilities? I see Eric Wright is on here and knows very well. There are people that are trained to deal with people with intellectual developmental disabilities across healthcare professions, and others who are not. Age. I've been a child psychologist all my life, including, I guess, when I'm in Frankfurt. But we know that there are some providers who don't want to see anybody under the age of 18. There certainly are a lot of providers that wouldn't see anybody under the age of 6. And yet there are young children and their families that need care. And again, the culture, ethnicity, racial balance, and so forth. What kind of payer sources are they willing to take, if any? We have a number of providers that are doing what we call boutique practices, or are taking cash on the barrelhead and not billing at all for insurance. Are they Medicaid providers? Are they Medicare providers? And then more recently, do they offer telehealth in addition to in-person services? And I do know from work on another committee that the state is creating a website for providers who are providing telehealth. So that's another way to get at that. So the bottom line, folks, is that the current licensure board data overestimates the number of practicing professionals and gives little to no information about where services are actually being delivered, again, because they have only a single address. So I have a recommendation on this last slide. If you could go to that, Aaron, thank you. To require all healthcare licensure boards to collect the following information at the time of application, in other words, the first licensure, and then with each license renewal period, so we can accurately assess our capacity. And again, these are the things that I just went over that most of the boards are not collecting at all. Again, the Kentucky Board of Nursing does the best job. We are working, there's several groups working on this. Kentucky Voices for Health is working on it from a network adequacy point of view. If we don't know what our workforce is, it's very difficult to hold the MCOs and other insurers responsible for having accurate provider directories and really making them useful for people so that they really can match up with the kind of provider that they're going to be most comfortable in seeing, the one that they think will be most able to relate to them and to their issue. A new coalition called the Kentucky Coalition for Healthy Children, and also my mental health coalition are working with KVH to find a sponsor. We may have one in the Senate that would put forth this legislation to make this requirement of the licensure boards. There is some cost involved, and so there may need to be some allocation of state funds, because when the websites have to be upgraded to be able to receive this information, but I think it's well worth it. So I guess I would say to you, when people talk about the workforce shortage, and we do have it, I think it would really be helpful if we would all say back, you know, we really don't have accurate information about what our overall capacity is. So last slide has my email address if you want to be a part of this movement in the legislature. And I won't take time. Well, if there's a pressing question, Beth, I'm happy to answer it. Otherwise, if people want to just email me with follow-up questions, I'm happy to respond to that.
Okay, this is something a little bit different in regards to what the MAC has looked at before. So I'm wondering how we move forward with this, because I think indirectly this affects Medicaid participants. It affects all Kentuckians at every level. So I guess I'm wondering, where we go from here and what suggestions MAC members might have in regards to these recommendations. Do we think that this is something that we could send on to the licensure boards? I'm not sure where our authority starts or ends in that respect. But I would like some discussion about what we think we can do about this.
Beth, I think you're right. This is probably a little bit beyond the purview of the MAC, but Sheila, that was a great presentation. All of the items that you brought up are things that we have addressed in one form or another. I know Dental Tac has had, network adequacy, concerns. All of the MCOs are being scored and required to have certain network adequacy, metrics. And it's right now it's a shot in the dark. I mean, you're chasing a 10-year-old ghost trying to figure out if you have network adequacy or not. This is something that I think should be championed by the different specialties. Because that's not only is it a service to our patients, our constituents in Kentucky, but I mean, this is, for a new practitioner looking to come in, they don't want to be beside 25 other people doing the same thing. They want to go to an area where they can be useful. I do think this is probably going to need to come from either the cabinet directly or with new legislation. I certainly will get our board behind your efforts, and I'll email you individually and see what we can do to help.
Thank you. I appreciate that. I think the other issue that I didn't put on here in the Deloitte survey talks about is the urban versus rural divide. And of course, we can't really accurately assess that until we really know where the services are being delivered. So again, it's an access to care issue for Medicaid members and obviously for all Kentuckians, but I appreciate that, Jerry. Thank you.
Veronica, would this be something the MAC could make a recommendation to the governor's office, perhaps since there hasn't been any work done on this since 2013, for another study to be done, and maybe noting some of the shortfalls in the Deloitte review and asking for a more comprehensive review of the workforce?
Certainly we could pass that along if you all made that recommendation. I think as someone kind of alluded to before, having the different associations contact the governor's office, or even, this is something that could be put in state law, and going directly to legislators to have something put in state law. Having that direct contact is probably more meaningful. Not that your all's recommendation is important, but the more you hear from folks, the more you're maybe moved to do something. So again, I mean, if you all have a recommendation and ask us to pass that along, we can do that, but it is out of our jurisdiction. And I do think it would bear more weight to have this, have each of the associations contact or have the providers contact either the governor's office or the legislature directly.
So how about this? How about if we make a recommendation to the governor's office, and that we also request that the tax through their professional organizations also make recommendations to the governor's office, and that kind of covers all the bases.
Is your recommendation for the governor to authorize another study?
Yeah, I think that would be a good starting place to ask the governor's office to look at doing another study that would be more inclusive and comprehensive than the one that was done in 2013. That think that's a good starting place.
wonder-
And I think it's also going to be important to support potential legislative action, like you were talking about, Sheila. So
Yeah.
I just add that into the other recommendations, Beth.
Yeah, I
Yeah.
think the recommendations to the tax could really be around not only the communication to the governor's office, but communicating to legislators, because as Veronica said, you know, it's really those people getting to the legislators, and you know, hopefully we get a bill sponsor, and I can let you all know what it looks like and so forth. I wonder if there's any information that the MCOs have about providers that could be helpful. And I'm not real sure what it would look like, because the network adequacy is the flip of this, certainly. And we, you know, I've raised questions about network adequacy from the behavioral health standpoint, because I think most of the insurers and MCOs count one behavioral health provider as the same as another. And again, they really are not. I've really advocated that they look at those behavioral health providers that can prescribe, for instance, those who can do diagnostic testing, and those who do therapy. I mean, there's really three kind of classifications of services out there. And I think for people trying to figure out who they need to go see, because I get those calls all the time, you know, would be helpful. So I don't know what role perhaps, or what data the MCOs might bring to this as well.
So it's a really complicated issue. So to try and hone down on any recommendation that we would make, is it reasonable, do you think, for as far as the NAC is concerned, to make those two recommendations, that we recommend to the governor's office that another workforce study be done, more comprehensive and more inclusive, and then secondly, that we recommend that the tax through their professional organizations contact their legislators? Or I'm not sure where to go with that.
Well, why don't we ask the tax to also follow up on the MAC recommendation to the governor's office, and to make, you know, reinforce that recommendation. And then if we have legislation in this session, for them to reach out to support legislative initiatives to make this happen when they're filed. And if it doesn't happen in 2023, because it's a short session, it will happen in 2024. There will definitely be legislation around this. I think that's the only way to accomplish it with the licensure boards.
Mm-hmm. Okay, so does somebody want to make a motion to accept that recommendation?
Well, since I presented on it, I'll make that motion.
Okay. Do we have a second?
Bobrowski.
Thank you. Any further discussion? All in favor, say aye.
Aye.
Anybody opposed? Okay, so moved. So we will send that recommendation to the governor's office and to the tax.
Thank you
Okay.
very much.
Thank you, Sheila.
Yeah.
Okay, so we've still got quite a bit of ground to cover and not a lot of time to do it. So I'm going to ask the tax to be brief in your presentations, and just give us your recommendations so that we can make sure that we cover all of our other business. We do have new business, and then we have 2 items of new business that we have to cover. So we'll start with therapy.
Yes, this is Dale Lynn. I'm the chair of the therapy TAC. And had three items that we'd like to bring to the attention to the MAC. Is the first one is First Steps, the extensive coaching training requirements added in 2018 has resulted in a huge time burden for providers with no reimbursement and no pay increase. Therefore, many providers have just dropped out of the program, leaving it, shortages for providing services to these children. And also the same, we have First Steps providers receive the same pay since 2005, and they're requesting a increase. And it is requiring providers to use the coaching and educational model in the home to provide services, but providers are required to bill therapeutic CPT codes based on a medical model, and educational services are not reimbursable by insurance companies and should not be billing and using those codes. And we're asking the MAC to facilitate by bringing the interested parties together for a meeting to look at what can be changed to decrease the burden on providers who are already stretched to the limit, and decreasing therapy workforce. That is the first item. Second item is we would like to bring to the MAC. We're jumping on the wagon of wanting more reimbursement for our services and our CPT codes. The flat Medicaid rates have not increased more than a few cents, and many of them actually have decreased since 2010. The therapy TAC is asking for the MAC to support increasing the therapy fee schedule. And the third and last item that was going to be brought to the MAC was the therapy TAC brought to the attention of Medicaid, the financial burden of the NCCI cotivity edit and the pains that it causes providers financially. We discussed this with last week with Medicaid, and actually over the last few TAC meetings to support removing those cotivity pairs from the NCCI edits that affect therapy financially. And last week we discovered that CMS has removed most of the cotivity pairs that impact therapy effective April 1st in 2023. And we just want to thank Medicaid for supporting that.
Okay, thank you. Next up is primary care.
Thank you. This is Mike Caudle. I'm the chair for the Primary Care TAC. I'm also CEO of Mountain Comprehensive Health Corporation, FQHC. We met in a meeting on January 5th of 2023. A quorum was declared. Our next meeting will be March 2nd, 2023 at 10 a.m. And we did not have a recommendation for the MAC. We did have a few things go on there. We had a presentation from Tal Curry, the Executive Director of Kentucky Office of Autism, on autism and the department's efforts, and also talked about it that autism is now the rate of 1 in 44 of people are on the autistic scale. And about the barriers in trying to find qualified people like BCBAs, they very, very hard to get, extensive requiring. Talking about the barriers that the people with autistic children are having trying to get care, that the only two main centers in Kentucky is University of Louisville and University of Kentucky. And otherwise out of state, there is one in Cincinnati, and there's small groups such as Pikeville Medical Center that start their AIDA center in Pikeville, Kentucky. And of course, it's of interest because we're trying to get one. But there's a lot of barriers to that, not only personnel, you also have reimbursement problems in this, because when you start talking about autism, you're talking about sessions lasting multiple hours as opposed to 15 minutes like in a primary care setting. And certainly something that DMS probably needs to look at and being more active in it. We also updated on signature provision on the discrepancy between FQHCs for 1 day and other primary care providers for 3 days. And that is being changed. It's currently in front of the regulatory review, and it's not being enforced, but it was one of the things we discussed. We made the recommendation on the dental workforce before that the MAC accepted, and we discussed that. We received a letter where it was presented to the secretary and has been taken under advisement, but at the same time, we were told that there's been a coalition formed made up of the 2 dental schools in Kentucky and the Pikeville Dental School that is getting ready to start, and to look at those type of programs. And we would perhaps be solicited to have a member of the primary care TAC to meet with them. And we also talked about the establishment of core quality indicators across all MCOs to give providers some type of consistency rather than trying to try to serve different regulations for each of the MCO providers. And the department is looking at that. Veronica Cecil told us at that time, the goal is that we do aligned effort across all the different levels. So DMS, the MCOs, and providers are all working towards the same set of measurable goals. We've not been there before. We've just started it. It's a heavy lift. The difficulty is in choosing those measures. We can't do everything, and that's going to be reported back to us on a quarterly basis. Veronica also told us about the submitting of a state plan amendment reference community health workers and to add them to the plan as reimbursable services being looked at to begin as early as July 1st of 2023. And that is currently pending in front of CMS. That's it.
Okay, thank you. Physician services.
Excuse me, Dr. Gupta dropped it in the chat. So since we can't hear her, I'll read that off really quick. It says, we met on Friday, January 20th, and had a presentation from the Millbank Memorial Fund on ways that the state can enhance primary care for Medicaid recipients. The physicians TAC will continue to focus dialogue on this subject and other barriers to access. We have no recommendations.
Okay, thank you. Pharmacy.
This is Kathy Hanna. The PTAC did not meet since our last meeting, so no recommendations. Thank you.
Thank you. Persons returning to society from incarceration.
Yeah, this is Steve Shannon. We met, we had a quorum, we approved minutes. We hadn't had a quorum the last 2 meetings. We got an update on the implementation of Senate Bill 90 and report from our managed care partners, as well as we discussed potential agenda items. And we have no recommendations. We're still eagerly anticipating the approval of the 1115 SUD waiver. Thank you.
Thank you. Optometry.
Yes, this is Steve Compton. We met, had a special call meeting mid-December to address our concerns and questions with the enhanced vision Medicaid benefits that that the department had announced. The department asked us to submit our concerns and outline specific areas of our concern in writing, and we did that. As of today, we have not received any response to this communication from the department. At this time, the TAC is not making any formal recommendations to the MAC because we are hopeful to hear back soon and would like to give the department the opportunity to properly address the concerns raised at the TAC. But we do remain frustrated with the lack of information and lack of response we've received. We will meet next Thursday, February 2nd, and we may very well have some recommendations coming out of that meeting, but we have none at this time.
Thank you. Nursing services?
I don't think Lisa was able to join, so I'll give the update. So we met on December the 8th. We reviewed some of the outstanding data requests that we had submitted, just reminded of those, and we've since gotten those. We spent most of the time talking about expanded Medicaid billing for school-based services with the changes that allow for students that do not have IEPs to be, those services to be billed in schools. Specifically, we talked most about reimbursement rates because nurse practitioners are being paid $7 and $8 for preventive health exams. They're not being paid on the preventive fee schedule. And so I think there was some work to look into why that is happening. We requested that there be an update to the school-based Medicaid billing technical assistance guide to look at the services that are included, because there's a lot of services allowable on a federal level that haven't been included in that document and that reimbursement. And so a committee's been formed. That committee actually met yesterday. Aaron had spearheaded that. And so that's some really good work. And there were no recommendations for the MAC at that time. We'll meet again this month.
Okay, thank you. Intellectual and developmental disabilities?
The IDD TAC did not meet in January. Its next meeting is scheduled for February 7th.
Okay, thank you. Hospital?
Sorry, this is Russ Ronaldo. I was on mute. We met in December, hospital TAC. We went through some old and new issues, but we don't have any recommendations at this time.
Okay, thank you. Home health?
Thank you, Evan Reinhardt with the Home Health TAC. We continue discussion on reimbursement rates for home health. And we had 2 recommendations for Medicaid to cover Plerex drains and to make supplies coverage and MCO charges for supplies public information. And that's all we have.
Thank you. EMS?
This is Keith Smith, new chairman for the EMS TAC. The only issue we have, not to make a formal recommendation, however, we have a number of EMS providers across the state of Kentucky that are not being reimbursed for trips that they're making because of a new pre-authorization form process that has been handed down to us. The form is nearly impossible for EMS providers to be able to complete because it's asking for information that is hospital specific, and hospitals can't really do it because it's also asking for information that's EMS specific. So we are meeting with these individual insurance companies, and we are supposed to bring back more information for our February meeting. That's it.
Okay, thank you. Disparity and equity?
Hi, this is Patricia Bautista Cervera. We had our second meeting on Wednesday, January 4th. We're just exploring on what are the main issues that we need to address. We have discussed the barriers about transportation for many of the populations in the rural and in the urban areas, and also the accessibility to immunizations, but we don't have any other reports or recommendations to the moment.
Okay, thank you. Dental tech?
Yes, this is Dr. Garth Bobrowski. We did have an emergency TAC meeting on January the 13th. We had 100% attendance for a quorum, but again, I wanted to thank Commissioner Lee and all her staff and works with her on helping us work through some serious dental issues across the state. We're just trying to move the needle, excuse the pun, but Kentucky oral health was 49th in the nation. But wanted to bring up one thing that a lot of folks may not be aware of, and I don't know how many of you all use the locum tenens to help fill in on staff, like for maternity leave. This thing has been on the books for a few years, and for some reason it's being taken out of the regulations to allow this. But it has been a very good way to have help come in to fill your offices, but it's being taken out. So I just want to make you aware of that. And the other thing that we're working on is this community health worker. Our next TAC meeting is February the 10th. At the present time, we do not have any motions to present, but I'm sure after this next meeting, there'll be some coming forward. Thank you.
Okay, thank you. And I was just informed that I skipped the nursing home TAC. It's not on the list that Aaron sent out. Is it? Oh, it is.
There we are.
They have not met since, I believe, October of last year. Their next meeting is in March.
But I am here.
Oh.
Greetings, last but not least. We're used to that, no problem. Right, that report is correct. We do have a recommendation though to DMS. We have a mutual problem. CMS for the MDS is going to sunset Section G by this October 1st. That is a critical component of the rate that sets the case mix. It's the physical assistance required for the patients in the nursing home. They're sunsetting that. There's no great solution. We've had an MDS task force that has sent over a recommendation for a crosswalk to DMS, and we'd like DMS to test this crosswalk using the historical data to see if we can get to a consistent output of the rates. There is another optional state assessment that can be done, but that's going to take, we've heard a great deal about workforce here on this call and meeting, and that's just going to take more time from nurses away from patients to do that other optional state assessment when there is a crosswalk. So if you all can test that proposal and get back to Kentucky Association, that's our ask. So thank you.
John, just a quick question, since it's been so long since your last meeting, did the TAC vote on that recommendation to be presented to the MAC?
It's within an MDS task force, so we had not been able to meet on that, but I will get back to them and see if we need to do the emergency as Dr. Bobrowski just mentioned.
Thank you.
You're welcome. Thank you.
Okay, I'm sorry about missing that. I didn't see that on the list.
Thank you.
Consumer rights and client needs.
Good afternoon, everyone. Emily Beauregard. I'm the chair of the Consumer TAC, and we did meet on December 6th and had a quorum present, and we do have a few recommendations. One of the items that we discussed most at our last meeting, and actually for a number of meetings now, is network adequacy. It's something that has been a big concern of ours, and for some of the reasons that Dr. Schuster already presented. We also know that most Medicaid members, or we assume, I should say, but in the ones, with the members that we talk to who are having issues finding a provider who will, is in their area and will take new clients, new patients, we hear that pretty frequently and learn that patients aren't necessarily aware of network adequacy rules and the rules that the MCOs, have to follow in order to provide an adequate network. And those rules are time and distance standards that again, Dr. Schuster presented on, but these are in statute, in regulation, and that's not enough. Just having that regulation isn't enough to really have that network adequacy met. And we know that there are requirements of the MCOs to provide reports of their network. But when you don't have great data from the licensure boards and there are a lot of gaps, that translates into networks that aren't necessarily as accurate as they can and should be. And all of this, translates into provider directories that consumers are using and finding that when they make a phone call to a provider, they're often being told they either don't accept that, MCO at all, or that they're not taking new patients, any number of things. Or if they are taking new patients, it may take 3 months to get an appointment. We hear that all the time. And so one of the things that we thought we could do through the consumer TAC is to work with DMS on a one-pager that at least provides consistent, uniform information about network adequacy requirements, what those standards are, what the process is to follow whenever you're having trouble finding a provider. And so we really appreciate DMS pulling together that one pager. In that process, we kind of recognize some gaps in how the policy really works in practice. And one of the things that we noticed is that while there's a process for, reaching out to your MCO and working with your MCO to find a provider, and the MCO is, I believe, encouraged but not required, although I think it should be required, to provide out-of-network care whenever they're unable to provide in-network care within those time and distance standards. There's no higher level of in that process to report whenever network adequacy is not being met, when your request for an in-network provider, just simply isn't being filled, and you end up not being approved for that out-of-network care. And so that is an area where I think we need to make some improvements in the Medicaid program. I think that DMS should have a role in, tracking any network adequacy violations and also making sure that those issues are resolved for the member. Right now, the recourse is that if a provider isn't available within those standards and the MCO isn't providing an out-of-network provider, then the member can choose to switch their MCO. But we know that this takes time. It puts a burden on the member who would ultimately, it doesn't even necessarily ensure that they're going to still get that provider within that amount of time. And they may have enrolled with that MCO for other reasons. So to make that their only option, I think, is putting more burden on the member than the MCO in this case. And again, it means that you're telling people, okay, well, you can switch, but that means that we have not a lot of good data on why people are switching. And we assume that a lot of people don't even realize that this is an option for them and probably just accept that they can't find a provider and end up not getting the care that they need, or having to wait many months in order to get that care. So there are lots of reasons that we need to improve this process and make sure that DMS does have more of a role in, in tracking when network adequacy isn't being met, and also in helping to resolve those situations. We know there are secret shopper audits going on, and at the same time that, we're hearing from MCOs that they're meeting network adequacy standards more than 95% of the time, while the secret shopper audits are finding it's sometimes 30 or 40% of the time. So there's a discrepancy there that we really need to dig into. And, beyond having better information and a better process for Medicaid members, to the recommendations that Dr. Schuster put forward, I do think that going, to the Kentucky legislature and asking for that uniform data to be collected from licensure boards would give us the information that we need to identify gaps in our networks and to start to be more targeted in interventions. It's definitely a first step in the process. It doesn't solve our network adequacy woes, but it's information that we need to be more targeted in how we approach network adequacy and the workforce issues. So we do have one recommendation related to the one pager at this time. We don't think that one pager is enough. So during our upcoming TAC meeting in February, we'll be developing additional recommendations to bring to the MAC. And then something else that we discussed at our last meeting that really relates to the presentation that Dr. Thoreau gave today, Terrio, excuse me, is related to doulas. And we have seen that, you know, with many of the MCOs, while this is a value added benefit, many are now starting to provide some amount of doula service and access to doulas. For some, it's a relatively small program or may only be offered in certain areas of Kentucky. But I think that's good progress. We were excited to, you know, see that there's a lot of work being done by many MCOs, and some of them have pilot programs that are collecting data and finding improved health outcomes for moms and babies. You know, I think that this data and the data, you know, that we have just, you know, beyond our Kentucky MCOs on the value of doulas and the impact that having a doula can make on the health of a mom and baby is enough for us to really strongly consider Medicaid reimbursement for doulas so that it would be a service available to all moms and one that would be, I think, more accessible because, you know, anytime you have reimbursement, you have more doulas that are able to participate and you end up having more access to those services. So that was the other item. And of course, the Medicaid renewals has been a big topic for us as well. And, you know, I think that it was good to hear Veronica's update earlier. We're very, you know, encouraged by all of the work that DMS has done to prepare for the renewals. Renewing 1.7 million Kentuckians in 1 year is going to be a Herculean task. And I do really want to just re-emphasize, because I think I've brought this to the MAC's attention before, just how important it is for this to be an all hands on deck sort of approach, and that providers and other Medicaid stakeholders will need to be sharing, you know, consistent information with Medicaid members and doing outreach and making sure that people understand what's happening and are updating their addresses and contact information, and that we're getting everyone enrolled or renewed, you know, who is still eligible. And for those who aren't, that we're helping them to find other types of coverage. But we're talking about at least 250,000 people, and about 50,000 or more of those people being children. So we really do need to all be planning on doing our own communications and outreach along this for this process. And I think that having some stakeholder meetings is going to be an important way to get everybody on the same page so that we're all sharing that consistent information and participating in outreach strategies. And so I'll just end with the recommendations that we made at our last meeting, actually our last two meetings. So the first is that DMS notify all CACs, the certified application counselors and connectors, on an annual basis of the release of the Medicaid open enrollment side-by-side value-added benefits. That's a really valuable tool that connectors use whenever they're helping somebody enroll and choose an MCO. Our next recommendation is that DMS post the network adequacy one-pager that I mentioned on the DMS website and require each MCO to post the one-pager on their respective websites and include it in their member handbooks. And the third recommendation is that DMS create a process for Kentuckians to apply for emergency time-limited Medicaid in advance of an emergency and be pre-approved to receive emergency time-limited Medicaid in the event of an emergency occurring within a 12-month period from the date of their application. So those are the three recommendations. We also voted to approve our 2023 meeting schedule, and our next meeting will be on February 21st at 1:30 p.m. and it will be virtual. Thank you.
Dr. Bobrowski has his hand raised. I'm not sure if he has a question.
What?
Dr. Bobrowski has his hand raised.
Okay.
Just a question for the consumer tax concerning the network adequacy. I'd be interested to find out if in dentistry, 4 of the 6 MCOs, as soon as they came into the state, shortly after they came in, they took our 2002 fee schedule and took 10% off of that. And that's what we've been getting in reimbursements across the board for years now. And I was just interested in, for consumers and not being able to find dentists, it's like our other tax, did the MCOs do the same thing to other tax? Or to other professions?
I don't know. That would be a question for DMS.
I'll ask them.
Yeah, those contract rates, I think are usually private, but I think it is something that we have heard, at least anecdotally. And I will say that there was a bill filed by Senator Alvarado last year to require a particular, the fee schedule be the minimum payment, I believe, for dentists, and it may be refiled again this year. I heard that there was some interest in refiling that bill under a different sponsor.
Working on it. Thank you.
Thank you. Children's Health. Okay, Jennifer, are you giving the report for the Children's Health TAC? If so, you're muted. Jennifer, are you trying to give the report for the Children's Health TAC? If so, you're muted.
I'm not sure which Jennifer you're trying to reach. I had accidentally unmuted a few minutes ago. I'm with Medicaid, but it's not me.
Okay, sorry.
I was trying to scroll through. I don't think I see anyone from the Children's TAC on today.
Okay, thank you. And then last up is behavioral health.
And I will go just to items that tie into our recommendation and to other items that are on under new business. We met on January 5th. We had a quorum and so forth. One of our TAC members, Mary Haas, representing the Brain Injury Association, presented her concerns about the potential loss of therapy services for members with acquired brain injury who are being served on the ABI acute and ABI long-term 1915C waivers. There was a robust discussion about that, and some of the background was presented by Pam Smith from DMS, who you heard from earlier. The change in therapy services across the waivers to the state plan is required by CMS. And DMS has tried to be in contact with providers, members, and families. The billing mechanism is apparently quite different if you go to state plan billing as opposed to waiver billing. And Mary continued to express concern that therapy providers who are very skilled and who have worked with the same clients for years, because remember, with acquired brain injury, those services are going to be ongoing, that they will no longer be willing to provide services under the new model. Several avenues for improving the flow of information between DMS and all stakeholders were discussed, and we do have a recommendation on that. We agreed that the best interest of all would be served with more frequent communications, if only to say that nothing has changed. And this issue comes up repeatedly, and I feel for DMS because it takes so long. They're working on things that they know are going to happen down the road. But once that word gets out to consumers and their families and to advocates that a change is coming, the anxiety level shoots up immediately. And it's true with providers too, because immediately is there more red tape? Is there going to be lower reimbursement charges and so forth? And then when there's dead silence for long periods of time, that anxiety just multiplies. And I keep saying to people, you know, let people know that you're still working on it, even if nothing has changed. That's information that they need, because otherwise you get all of these rumors and people kind of playing off each other in terms of what's going to happen. So our recommendation to the MAC from the behavioral health TAC is that DMS communicate on a regular basis regarding the changes in the ABI waivers with regard to access to the various therapies, which will now be covered under the state plan and not under the waiver. These communications should include ABI providers, therapy providers, Medicaid members and their families or caretakers and advocates, including representatives of the Brain Injury Association of America and the Brain Injury Alliance of Kentucky. Specifically, we also recommend that DMS communicate with the BH TAC, the Therapy TAC, and the Consumer Rights TAC at regular intervals to assure that stakeholders have pertinent information on the proposed changes, their implementation, and any problems in accessing therapy services. Under our new business, one of them was the issue that Dinah brought up earlier, and that is that the BHSOs and the alcohol and other drug entities, AODEs, have not seen what the new rates are, and obviously there's a lot of anxiety about that. So we appreciate the clarification given earlier in the MAC meeting from Veronica about that. We also had a discussion about the RFP to manage mobile crisis services across Kentucky, and we were able to get some background information about that. The final issue is really a very significant one, and it's listed under new business for discussion, but it has to do with the change in CPT service codes, which now our information was that they are now no longer available for extended time periods. In other words, for therapy services, for instance, that run more than 1 hour, and that those have been deleted. I will tell you as a child psychologist that the more significant the illness, and we're talking about, for instance, children with extreme forms of autism, we're talking about children with severe emotional disturbance, the therapy sessions very often go longer than an hour and need to go longer than an hour. And we need to come up with some way very quickly. I know the Children's Alliance, which is our child care delivery service for these kids, are really encountering problems. So I hope our discussion under new business will help with that. The next meeting of RTAC will be March 9th, and I appreciate your support for our recommendation about the ABI waivers and therapy services. Thank you.
Thank you. Okay, so we've got about 4 minutes. So obviously we're going to go over time a little bit, but let's try and stay as close to time as we can. Under new business, what Sheila mentioned, the American Medical Association has deleted the CPT code for add-on codes for extended services, codes 99354 and 99355. These claims are no longer being accepted as of the 2nd of January of this year. This is a serious issue affecting behavioral health services throughout Kentucky. And what does DMS plan to do to remedy this problem? And Eric, did you want to speak to this?
Yeah, I became aware of this from Transformations for Hope, which is an provider agency here in Louisville, Kentucky. And I guess the information was disclosed to providers in early January about these changes, unbeknownst to a lot of people. And I think the biggest thing is just clarification about this and what the plan is moving forward. Often the case, like I had suggested when talking with Dr. Schuster about this issue, it's often the case you're working with clients, as I do in the area of clinical mental health. There's still work that has to be done to process some emotional trauma. And those codes often allow you to be able to extend the session up to 30 minutes, which is necessary at times, 30 minutes to an hour, which is necessary at time. But currently now those codes, as we understand, being removed has provided a real complicated situation with clinical and mental health providers, behavioral health professionals. And so that's the reason I wanted to bring it to the MAC and just see what remedies are going to be out there, what solutions are going to be out there for patients under a medical model that do have needs that go beyond an hour at a time.
I would request a clarification with, I was in DC with CMS representatives back in November, and I believe they had changed the add-on code. It was an incremental add-on code 99418, and you would bill, a unit for every 15 minutes. Is that not being reflected in the Kentucky Medicaid fee schedule?
So let's just talk about what do we normally do. Annually, the AMA updates coding guidelines. They add codes, they delete codes, and we implement those. We don't generally, though I understand the impact that this is having to providers and certain services, we don't normally send anything out that because what we require our providers to do is to follow coding guidelines, and we don't provide guidance on coding. Providers should understand what the changes are. They should consult a professional coder if they need assistance with that. So, again, these happen annually and we don't generally send anything out. We have to follow coding guidelines, and we are preparing a letter, and we finalized it. We'll be getting it out there that just is basically going to say this. We have to follow what the coding guidelines are. So for the codes that are deleted, they are going to be removed from our fee schedule. You are correct that there is guidance out there about, and this is AMA guidance. Let's be clear of who is driving this. There is guidance out there about what to do what the change, how the change affects the services and the codes being billed and what you're supposed to do. So, we're providing links to that. Had we, and this came out, this was being discussed back in October, I think, by the AMA. Had we understood a little better about the impact that it was going to have to providers, we would have done perhaps a communication sooner. But there isn't really anything we can do. We have to follow coding guidelines. So, certainly welcome to hear your feedback, but we're following the AMA guidelines.
But just to clarify too, though, those codes, because I was brought into this by Terry Lloyd from Transformations because of the work I do contractually through them. Often the case, I do work with clients and we do go beyond a typical 1-hour session. Not often, but it does happen at times. Therefore, what I'm understanding is that this was a topic that had been discussed earlier though, right? And there is a workaround is what I'm understanding. Is that correct?
The AMA has guidance on what to do to replace those prolonged codes. And we will put the link to that guidance in the chat so that you all can quickly get to it if you've not already found that information. Kelly, can you do that for me, please?
Yes, this is Kelly Kitchen. I'm actually a certified coder and I've done research on this topic for Medicaid. And there are, just like Veronica said, there is no replacement codes for the add-on additional 15-minute or hour increments. And at this time, AMA has no intentions on replacing those add-on codes. I know the mention of 99417 and even I believe 99418, but those are codes that are not allowed to be used as a replacement code for these. So my understanding is from some of the trainings that I've taken on the behavioral health add-on codes is there is not going to be a replacement for the ones that were deleted. And at this time, they are suggesting that there is only going to be the 1 hour, 60 minutes. Now they do notate that should you do psychotherapy at the time of an E&M service, then there is a code, an add-on code for the E&M service. That will be the only add-on code allowed with psychotherapy.
Okay. Anybody else have any comments regarding this?
Did the AMA have a psychiatrist in their group? I mean, this is just unbelievable.
Yeah. So we are continuing to dig into it, trying to find out what other states may be doing. We're planning a conversation with the managed care organizations. We're all in a very difficult position here. And so, we'll continue to see what options are, but for now we also have to follow coding guidelines.
I'll use a distinct example. If, we see clients in a medical model approach with behavioral health being one, and we're talking about capacity in our state to be able to provide these services. And right now, the capacity is lacking in behavioral health professionals. And the result is that oftentimes we find ourselves in very complex situations with clients that do require additional time that's not previously scheduled, right? But I would suggest too that if you're in a true medical model approach, you don't just stop a procedure in the middle because they only say you have an hour, right? If you need to be able to do a medical procedure, and I'm using this in a medical model approach, right? You don't just stop seeing a client and say, hey, listen, sorry, we got to stop. It's not fair to the consumer. It's also not fair to the provider, in my opinion. And I think it definitely needs to be something we do advocate and try to seek solutions to in our Commonwealth, because the truth is that we're in a mental health crisis and we need to be able to address these clients by utilizing additional services and add-on codes appropriately when needed. If they're that would avoid us to have to go hospitalization, psychiatric care, EMS involvement, those type of services, which are going to be more expensive for Medicaid in the long term. So I'm I'm fervently advocating that this definitely needs to be reviewed and evaluated further.
For clarification on the AMA 2023 coding guideline, coding assistance, where it states 99354 and 55 have been deleted, it specifically says use 99417
Yeah.
for prolonged evaluations.
Is
That
that
was
able-
just for medical though, not behavioral.
Yeah, 99417, if you look at 99417 in the coding guidelines, it tells you what codes it can be billed with and what codes it cannot. And that, sorry, I'm trying to turn to that page now. Should have had it.
And that may be medical, not therapy. I would qualify that, but
Yes, that is correct. They're using a 99417, which specifically states you can only use that with medical 99205, 215, 245, 345, 50, and 483. So that is not going to be allowed to be used with behavioral health codes.
So I have a question, Dr. Pardon, if you don't mind making a comment. I'm not on the TAC or on the MAC.
Okay,
Bart.
if you can be brief, because we really do need to move on.
Sure. Well, I just want to reinforce that I think this potentially puts some providers in some very awkward positions in terms of providing services that their clients need, but aren't allowed to bill for it. So, I mean, I know that Medicaid has to follow the guidelines for the codes, but is there, and I'm sure, Veronica, I'm assuming this is what you are looking at, is there a way to work around this or have other codes that are billable and are reimbursable by CMS? And because obviously the need is there, and the ultimate requirement for Medicaid is to provide the services that the members need. And I think this, in many cases, flies in the face of that. So I just think that, I mean, I don't know if that's what you are looking at as another set of codes. If you look, there's some suggestions for that in the chat about other types of codes that you could use, allow them to go beyond 1 hour.
We are exploring other options, but for now, we do have to follow coding guidelines.
Okay.
Okay,
This is
so
Steve Shannon. I'm on the behavioral health TAC and other stuff, but regardless, it's such a pressing issue because it was a code that was used as needed. If providers weren't using the code as needed previously, this would not raise to people's attention. And I understand, Veronica, it may not be your issue, but we need to figure out some way, or we're going to further aggravate the behavioral health shortage because people are going to be reluctant to be a Medicaid provider at risk of providing services that are currently maybe undercompensated to services that aren't compensated. I just think it's an access issue. We're putting parameters around services that is just going to impact the individual servant supported by the behavioral health system. It's just bad policy, in my opinion.
can we put this back to the behavioral health TAC to work on this with DMS and perhaps even get some more information from the people at AMA that do the coding? I think it's the RAC. And then we can bring this back at our next meeting.
Yes, we will do that. The BHTAC will meet again before the next MAC meeting. There are services like EMDR that are so important, and it's a 90-minute session. I mean, that's what it takes to do that service. And Eric's analogy with the surgery or whatever, although that's not usually time-based. And Veronica, I understand that you all have your hands tied, but let me be in touch with you because I really think every state has to be looking at this, right? And what's CMS's response to this?
CMS's response is they're following the correct coding guidelines and they expect states to follow the correct coding guidelines. So that
Regardless of the disaster that it's creating. I mean, that's the part that I'm just befuddled.
Yeah,
by, and
I can imagine that they're hearing from folks. You know, again, we reached out because we're trying to find other options. What are our options?
Yeah.
Okay,
Well,
so.
Yeah,
so-
let us take it up, Beth, and we'll see what we can do. We're the ones that are most affected by this, but it really is like a.
We'll talk about.
Sheila, is it possible to find out when the AMA board meetings are and get a representative from our Medicaid to be heard on the AMA board meeting?
I think this.
I don't know how all of that happens, but.
I think this takes
that
place
out.
May meetings. I think this takes place at it's called RAC, R-A-C, and I don't know what that acronym stands for, but that's where these discussions take place. And I can probably get you some more information about that, Sheila.
Okay. Yeah, and I'm, there may be some pressure that could be brought to bear by some of the national mental health organizations too, like NAMI and Mental Health America and that kind of thing. I mean, I think we need to be playing at that level, would be my guess. If they're saying that they just willy-nilly deleted them and there's no workaround and they don't intend to put them back, we need to change their mind about that, quite frankly. And in the meantime, we need to try to figure out how we get services to the kids, particularly to the kids, but also to the adults with serious behavioral health issues. So I'll be in touch with folks. Thank you. And Eric, I'll let you know when our next BHTAC meeting is, so you can be a part of that discussion as well.
Thank you very much.
Yeah.
Okay, thanks, everybody. And under new business also, Peggy Rourke had an issue she wanted to bring forward. And Peggy, I'm so sorry, we are running short of time. So if it's possible, could you keep it very brief?
Yes, this is Peggy. I with some parents, and it's been brought to my attention that with rehabs that Medicaid is only paying 28 to 30 days for inpatient. As we all know, chronic users, that's not enough time. They need like 6 to 12 months and then some intensive outpatient programs. I was looking at my notes here. We need evidence-based studies. We need to create longevity of use and dual diagnosis and trauma factors and intensity of that. One size does not fit all. Another barrier that we have teens, as we all know, that's getting on drugs, and there's not much access to help them. They have to wait till they're 18 to get help. We have people, a lady was in jail. She got released and she died, she OD'd. We need to do better and have, people that's been on drugs for 10 years, 30 days, and, having mental health and substance abuse. Maybe the lady that got out of jail, if we could have got her to a rehab, maybe she'd be here today. That's all for right now. If anybody comment or would like to chime in.
Do you have a recommendation for us, Peggy, or were you just providing information?
Yeah, I would like to recommend that all the MCOs take a look at this and come back and see what we could do, or what, I know money's a factor. There's probably a lot of things, just like what we was just talking, 1 hour of counseling is not for everybody.
Yeah, I think this work, we have a lot of information we could provide back. So maybe the best approach, given the time constraint, is we'll take that recommendation if the MAC passes it, and then we can provide additional information in response.
I appreciate that.
Okay, so we have all of the recommendations from the tax. We have recommendations from our new business. Would somebody like to make a motion to accept these recommendations?
I'll make that motion, Sheila Schuster. That includes the recommendations around the workforce shortage as well, right, Beth?
Absolutely.
Yeah.
All of the recommendations that have been made today.
Yeah, thank you. I'll
I'll second
recommend.
it.
Who is the second?
Peggy.
Thank you. Any discussion?
No.
All in favor? Say,
Aye.
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 anybody opposed? Okay, so moved. Thank you. Anybody else have any other business they'd like to bring
Yes,
forward?
this is Erin with Medicaid. I just wanted to make a quick announcement. I wanted to introduce Kelly Sheets. This is her first MAC meeting. She is going to be my new partner in crime, helping me tackle all the MAC and TAC meetings. I am not going to be with you guys for your March meeting, as I will be on maternity leave. So I will make sure that you guys have her email address, and I've been introducing her to the tax as we've had meetings. If you could just please make sure you're copying her on any MAC and TAC correspondence, I would greatly appreciate that, and I will see you guys in May.
Okay.
Good luck.
Thank
Yeah,
you.
we wish you all the best, Erin. Okay, anything else? Okay, motion to adjourn?
So moved.
Okay, is it?
I think you do it by acclamation. Everybody says, yes, let's adjourn.
Yes, thank you.
Yes.
Thank you.
Thanks.
Bye-bye.
Bye.